My name is Maulik, Joshi, and I'm the president of the Health Research and Educational Trust. And joining me here today is Dr. Atul Gawande to talk about improving surgical care in our country, considering the use of clinical interventions, such as checklists, and cultural interventions in improving care surgically for all our patients in our country. Atul, thank you for joining us.
Thank you, Maulik. Really fun to be here.
You've seen great success in the use of checklists in the hospital operating room. What do you hope to accomplish as you expand this work to the ambulatory surgery centers and hospital outpatient surgery departments?
Well, it's a huge opportunity. The story of surgery has evolved over the last 20 years so that we've gone from being mostly hospital-based to mostly outpatient surgery in ambulatory surgery type of settings. We're doing 50 million operations a year for a population of 300 million people. And we know almost nothing about the quality and outcomes and how to make them better in the ambulatory setting. What we know is that when we intervene with a very carefully developed and tested checklist for surgical care, that putting it all together, inpatient and outpatient surgery, that we see reductions in death of more than 1/3 in multiple studies. We know that we can reduce infections. We know we can reduce non-infectious complications. We know that we can make teams work better and like working together and communicating better together. But bringing it into ambulatory surgical centers where you don't have those inpatient components is totally new. And we also don't have a handle on how many of these patients end up in an ambulance after their outpatient surgery. How many end up in the emergency room? How many end up having to be transferred over and put into the hospital and then transferred into an inpatient type of setting? We know that a simple checklist is powerful because it takes the complexity of what a team is trying to do and make sure that it comes together reliably the same way every time, with some humility about the fact that we do make errors, that things can go wrong, and some real discipline and teamwork for how to minimize the likelihood that those things occur. So the hope is that we start to change the basic practice that exists in ambulatory surgical centers to become that higher level of a system, and then to change the outcomes.
As you think about these outpatient ambulatory settings, do they present unique challenges in terms of the implementation of the work?
It's a completely different environment from a hospital. The physicians are coming and going. They will be off-site hours after a patient's operation is done. They will have certain kinds of capabilities not at their fingertips, like blood transfusion, like specialist capabilities who can just land right on site if something starts to go wrong. Also, those expectations. The expectations of the patient are, I'm in and out of here. This is going to take not long at all, and we'll be just fine. But we've moved extremely complex surgery into this setting. We have moved a massive scale up of endoscopy, like colonoscopy, into these environments. And we know that things go wrong. We know we have to be well prepared for it, and we know we have to be able to reduce our likelihood that these things occur. The approach we've taken has been used in ambulatory surgery centers across the country and around the world. There are very positive reports of how well it's gone, but nothing done in the kind of systematic way with real evaluation that our partnership together is getting to produce here. It's a big deal. This is going to set the new standard for what ambulatory surgery care will be in this next decade.
And if I'm an ambulatory surgery center and I'm using the surgical safety checklist, why should I participate in this program?
Well, so one of the things we see is that there are plenty of people who are adopting the kind of systematic approach that the Safe Surgery Checklist takes. But there are two things that we see as real opportunities. Number one is being able to have a chance to upgrade sometimes the gaps. Everybody who's put the checklist in knows that there are surgeons who don't want to follow along, that the team communication is not where we could have it. And the opportunity to move it up to that next level of performance is opportunity number one. But number two is to pair it with an evaluation where you are part of having not just pioneered it in the early adoption phase, but then helped us gather the information so that we move it into lots of other places. So, you know, the places that participate would be ones that help transform not only themselves, but provide the experience and the evaluation that lets us show what the future standard is of this care.